Okay, class. Apologies for the little dropout there. Got a few more things to cover in the diabetes lecture, and we'll kind of get into that now. So, as we were talking about on the previous part of this lecture, that this graph here describes the response to an oral glucose tolerance test. Right, as you can see here, we've got a patient who's normal, not non-diabetic, and then someone who with type 1 diabetes, right? So again, we see this, if we give someone a bolus of glucose, which is what we do in a glucose tolerance sense, we load them with glucose to see how they respond, right? So their blood glucose goes up, right? But eventually comes down over time, right? We eat, digest food, enters into our bloodstream, insulin's released, all those other different factors released, and we uptake glucose into our cells, particularly our muscles. And then again, this is primarily achieved through insulin, right, which spikes as we eat, and as blood, glucose kind of gets into our blood, or glucose gets into our blood to be uptaken. So that spikes, and it also kind of comes down commensurate around the same time with glucose, right? It follows a typical pattern. So insulin spikes as well, comes back down. Now, in a type 1 diabetic, remembering that they do not produce insulin, right? They don't produce any insulin. So when they take in a bolus of glucose, blood glucose elevates quite dramatically, actually, and it stays elevated for a prolonged period of time. And this is because, even for the same amount of oral glucose intake or uptaken or consumed, they don't produce any insulin. There's no insulin response, right? And that's the way that we kind of detail or describe or distinguish someone with who's a type 1 diabetic or an insulin-dependent diabetic with also a type 2 diabetic. So in a type 2 diabetic, you'd see a similar elevation in blood glucose, right? They would still have problems uptaking glucose, but you actually would see insulin spike and stay elevated, right? Because with a type 2 diabetic, insulin production isn't so much the issue. It's like the insulin that they release just doesn't work. So blood glucose still stays elevated, right? We can't take any of that blood glucose into our cells in diabetes. But in a type 2 diabetic, the issue is that it's not the issue. The issue isn't that they don't produce insulin. They produce enough, too much really, because they're trying to make it work and make it signal and cause that uptake, but it doesn't work, right? I mean, they can produce as much insulin as they want. The sensitivity of all those, receptors is diminished, impaired, or completely gone. So blood glucose still stays elevated. So again, it's how we distinguish someone, who's diabetic versus non-diabetic, and then even within looking at different responses of insulin, we can help distinguish whether someone is a type 1 diabetic or a type 2 diabetic. Now, the general signs of someone with diabetes, the two probably most common are your frequent urination and frequent thirst. Is actually kind of the root word of diabetes, kind of what it means, I believe, in Greek. And then fatigue, vision changes, blurry, glaucoma. I believe it's the second leading cause of blindness in the world. So your vision gets affected by some of the glycation that happens in the retina, as well as the blood vessels that go to the retina. They may have issues with hunger, just keeping things regulated. Again, like if you struggle, maintaining, blood or glucose, being absorbed into your cells to produce metabolic work, you're going to have these feelings of hunger or lack of energy as well. And then there's issues with wound healing, right? Because of the glycation of tissues, reactive oxygen species, or oxidative stress. That's really going to impact healing, as well as blood flow. We see blood flow changes in these patients too because of the reactive oxygen species and oxidative stress as well. Weight loss, jury's still kind of out on that in some respects. It's more of an unexpected weight loss, and that has to do with, again, just not being able to nourish ourselves as well as we would like. And then the polyneuropathy, and we'll get into that in a second. So, one thing I want to stress is that, polyneuropathy typically occurs later in life in a type 1 diabetic, especially if they manage it well. Type 2 diabetics, it can occur pretty early, so that's another way we kind of distinguish the two. But I want to stress that it's a polyneuropathy. Often people only think of the sensory neuropathy, right? So diabetes has this classical or stereotypical stocking and gloves distribution of their paresthesia, their numbness, where they first lose sensation in their feet bilaterally. We assess this by doing monofilament tests. You'll learn more about this in later courses in tegumentary, but looking at, do they have, they're still able to detect, I believe it's 15 grams, 15 gram fine needle. And if they lose that protective sensation, they have a high risk for developing, an injury or diabetic lesion in the foot, which can lead to eventually amputation because they really struggle with wound healing, and that wound could end up becoming, gangrenous or ischemic, leading to, or infected, all kinds of problems, and eventually requiring maybe, amputation. They actually say the best way to treat a diabetic foot ulcer is to prevent it, because if you get one, it's really only a matter of time, even if it's a toe, where a toe becomes, a half foot becomes, below ankle, then a below knee, and then you're running out of problems here, especially if the blood glucose isn't managed. But again, it's all due to damage to the vasa nervorum, which is the blood supply to nerves. And again, our blood vessels diffusely in patients of diabetes are affected. And it's, again, that reactive oxygen species, that oxidative stress, the glycation, those advanced glycation end products, the AGEs and RAGEs. Those are causing diffuse damage, and it's going to affect the blood supply and the nerves themselves. But there's also motor nerve. The motor nerves are also affected, and the autonomic nerves, especially looking at the processes that allow us to regulate cardiovascular responses and sweat glands. Temperature regulation is actually a big problem in diabetics, being able to sweat adequately and dissipate heat. So something you need to really be aware of, that there may be abnormalities in terms of some of the cardiovascular responses to exercise. They may struggle exercising outside because maybe they lost some of that sympathetic control to help dissipate heat when we're exercising. So you need to be mindful of that. Now, again, here's a little map of that stereotyped diabetic polyneuropathy, again, showing that classical stockings and gloves. So stockings, the feet, and gloves, and hands. But the sensory neuropathy can have multiple different manifestations. Again, it's the damage is diffuse throughout the body, and we just typically see it in the legs first, and then in the hands. And again, it's a lot of it's due to the blood flow to those nerves. That's what gets damaged. And again, like I mentioned, retinopathies. If we start having damage and glycation and ischemia to the retina, you can end up having issues with blindness. It's a big problem in diabetics. And as we said, we look at A1C, which reflects how much your hemoglobin in your red blood cells are glycated, which reflects more or less glucose levels in the blood, right? If you've got a lot of blood glucose, it's a high probability that your hemoglobin are going to get glycated. So if you have a higher percentage of those hemoglobin glycated, that indicates poor blood glucose control. It should be less than 6. Ideally for a diabetic, for most people, it should be around 4. It should be pretty low. And as you see, as we start going higher and higher, the prevalence of retinopathy kind of skyrockets. It's a big problem, with blindness and vision changes in diabetics. And then I do want to touch on, we're getting into some different conditions here. So metabolic syndrome, this was once referred to as factor or syndrome X. It's had a lot of different terms over the years. Metabolic syndrome is what we're going with now, I believe, with the ICF and World Health Organization and other organizations. It's basically, these are patients who are not type 2 diabetic. They're not diabetic yet, but they're kind of at a high risk for it. So it's people who meet 3 out of 5 phenotypic criteria. So large waist circumference, elevated triglycerides, low HDL, so low hyperdensity lipoproteins, and we're going to HDLs are basically like our scrubber bubbles, which kind of eat up and absorb all that low density lipoprotein, which causes plaque lesions. Hypertension or elevated, blood pressure, elevated blood glucose. So it's not full-on diabetes, but their blood glucose is poorly controlled. And they obviously have all this, increased low-grade inflammation, CRP is elevated, TNF-alpha was probably elevated. So they're at risk for, other, full diagnoses, for heart disease, for diabetes. You may see this referred to as Metabolic Syndrome. And again, it's just a graph here describing it. Not exactly diabetes, but pretty close to it. And again, a lot of it's related to that, central or visceral or abdominal obesity. So we'll get into different types. So diabetes, two general types. Type 1, a little bit more rare, accounts for about 10% of cases. It's something that develops in childhood. We think it's an autoimmune disease, essentially, that attacks the pancreas, the islets of Langerhans. Was used to be referred to as, childhood or juvenile diabetes. Now it's more or less type 1 diabetes or insulin-dependent diabetes, and we'll kind of unpack that in a little bit. And then there's type 2 diabetes, which we had historically referred to as adult onset diabetes. But as we're learning, as we've talked about, we're seeing a lot of these, we're seeing type 2 diabetes in people in their 30s and even in kids. And it's really related to obesity, right? Or related to poor health, poor metabolic health. Now, we call this non-insulin dependent or NIDDM. We'll unpack that because generally, again, type 2 diabetics, they still produce insulin. It's just the sensitivity of your body to insulin is impaired. But there are some rare situations where they stop producing it as well. And we'll get into that in a second. And there are other conditions as well that are diabetes secondary to another condition. So any disease of the pancreas, pancreatic cancer is a big one. Gestational diabetes, we can see, diabetes developed during pregnancy, which can resolve at times. Long-term corticosteroid usage, because again, corticosteroids are going to spike blood sugar. It's basically synthetic cortisol that we're taking. Beta blockers as well. And there's other rare diseases and hormonal disorders, Cushing's syndrome being a well-known one. And then going down specifically type 1 versus type 2. So type 1, again, it's typically something we pick up in childhood, or we detect in childhood. The onset 6 to 13 years, but again, it can occur in adults, right? But typically it's something we see very early on. It's due to a destruction of the beta cells and the islets of Langerhans in the pancreas. And that's where we produce our insulin. So we don't have basically the factory to produce the insulin. We don't have it anymore. So again, like that graph shows, when they take in a bolus of food or glucose, in the OGTT, they don't have an insulin response because they have nothing to produce insulin. The hallmark of this, again, elevated blood glucose, but they don't produce insulin, right? Insulin dependent. They're going to be needing synthetic insulin injections for the rest of their life. Then type 2 diabetes, right? So we had called this adult onset. Again, we're seeing it earlier and earlier as the obesity pandemic, the physical inactivity pandemic, all those begin to elevate. We're seeing this even in kids nowadays, and it's strongly related to that central obesity. Now, the hallmark of this is insulin resistance, right? They produce insulin, but insulin's function, or functionally does not work in their body. It doesn't, we don't see glucose get uptaken into the muscle because the pathway for insulin to do that, it just doesn't work, right? They produce insulin, there isn't that response to dilate, the blood vessels, uptake, all the other things are affected as well. So insulin is produced, it just doesn't work. The cells are no longer responsive to it. We think in some respects this is due to the fact that if you chronically are blood glucose is elevated because you're not eating well, your body sort of starts habituating to that, and you lose the sensitivity of insulin to uptake glucose, because your blood glucose is constantly elevated because of poor diet. We also think inflammatory changes affect this as well. We described how the obesity impacts the insulin's response in terms of dilating blood vessels that take in glucose into the muscle from the blood. Now, there are some situations in patients with type 2 diabetes that continue to have very poorly controlled diabetes, that they will get to a point where the beta cells in the pancreas just are done. They go to burnout. They stop producing insulin, and we call that beta cell burnout, right? And this is where a patient who was a non-insulin dependent diabetic, a type 2 diabetic, actually becomes insulin dependent as well. So now not only do they have a problem with insulin sensitivity, they also now don't produce insulin, which is a big problem. So these are patients who, again, chronically poorly controlled diabetes. They don't follow their medications. They don't keep, they don't follow dietary recommendations, and eventually, like I mentioned, with type 2 diabetics, we see insulin just overproduced. And it can get to a point where the beta cells have just burn out, right? They're no longer working as well, and that's a big problem. So again, just quick review again in terms of complications due to diabetes. We have here again. Where's my? Here we go. Heart disease, eye complications, kidney disease, really anything that's going to be affected by or receive a blood supply, which can be affected heavily in diabetes, is going to have potential problems. Now, we'll go over different syndromes that you'll encounter when blood sugar is not in any ideal level, right? So hypoglycemia is when we have glucose levels below 70 milligrams per deciliter. For a diabetic, and again, everyone's a little bit different. You always kind of go by their historical trends, but typically we use less than 70. Now, in early stages, hypoglycemia will feel, if any of you have woken up, didn't eat, and then maybe worked out really vigorously, you get this, you may get a little, fatigued, you may have a little bit of shakiness, maybe a little bit, uncoordinated. That's kind of what early stages of hypoglycemia feels like. You might be a little bit pale, you may be sweating, there's going to be this sympathetic response that we'll see, palpitations. So that, in that certain sense, you want to make sure that we get glucose into that person to bring their blood or something to bring their blood glucose back to normal. Now, if it prolongs, very severe symptoms can be abnormal behavior, confusion, loss of consciousness, right? So the goal is to never let it really dip too low. And our goal with a diabetic, really anyone that's keep our blood sugar fairly consistent, but we want to prevent really low points and really high points. We don't want large fluctuations. We don't want peaks and valleys. We want things to kind of be even keeled. We don't want this. We want this, small little peaks. Now, hyperglycemia, often asymptomatic, kind of similar to blood pressure, right? Asymptomatic even at really high levels. Now, again, everyone's going to be a little bit different in terms of when they start getting symptoms. If you chronically have high blood glucose, you may not start getting any of these symptoms until maybe 240. But generally, we start seeing issues maybe above, symptoms when people's blood glucose stays elevated above 200. Now, early symptoms can be that classical diabetic, symptom: frequent urination, increased thirst, blurred vision, some fatigue, maybe a mild headache. And then more severe, right, you might start getting a little bit of confusion, right? You might feel a little weak. You might start having different, abdominal pains, a little bit of nausea, a little bit of vomiting. And if it gets really bad, you can end up going into this a state of ketoacidosis, right? Which will produce, we're not able to uptake any glucose into our cells, or diabetics specifically, they start relying on the metabolism of fats and proteins, which produce ketones, which will cause the this fruity smelling breath when they're metabolized, or these ketones. So again, ketoacidosis caused by metabolism of fats and proteins which produce ketones. This is done when there is insufficient glucose intake, right? So we can see this in a hyperglycemic state, right? When there's plenty of glucose in the blood, but we can't take it into our cells. Like we don't have a process for uptaking glucose because insulin, either we don't produce insulin or insulin's just not working, right? And there's resistance to it or lack of sensitivity. So we start trying to burn anything to keep our body alive. So we start breaking down fats, we start breaking down proteins, right? This is where we think some of that weight loss may kind of come from in people who don't have, they haven't recognized themselves as having diabetes. Again, it's more common in type 1 versus type 2. And again, the early signs are just very similar to someone who has hyperglycemia, because often this occurs in hyperglycemia. And again, the hyperglycemia occurs because there's no process to take in sugar, the glucose in our blood. So you start breaking down other substrates, fats and muscle, which are going to be coming from your muscles, right? Or proteins, which are coming from your muscles. So we typically only see this at really high levels, 240 or above, but again, it can be a little bit different depending on the person. If it gets really severe, again, you can start getting those similar symptoms and signs as we see just any hyperglycemic event, right? Coma, difficulty breathing, vomiting, abdominal pain. Often diabetic ketoacidosis is the first sign of someone who has type 1 diabetes, but it wasn't recognized. And it's usually triggered by an uncontrolled blood sugar, missing several doses of insulin, or like a severe illness that causes their blood sugar regulation and homeostasis to be completely out of whack. Now, in terms of exercise for a patient with diabetes, right, there are some general rules to follow. Probably the most important one, anyone who's a diabetic, right, you want to make sure you have a conversation with their primary care provider, whether it's their, whoever's managing their diabetes, whether it's their PCP or their endocrinologist. Like, have a conversation, because exercise will affect blood glucose, right? It will make insulin a little bit more sensitive. It will lower their blood glucose. But you don't want them, if we don't adjust the medications, it can cause a hypoglycemic event and you have problems, right? So you got to be mindful of these things. So always have that conversation, or encourage your patient to say, hey, reach out to your PCP or whoever's managing your diabetes, and tell them you're going to be starting an exercise program so that we can adjust, or at least monitor your medications accordingly. Now, we have some general rules of thumb for blood sugar being too low. Now, if your blood sugar is generally if it's below 100 for a diabetic, we recommend that they take a unit of glucose before exercise and then recheck. We call this the 15-15 rule. So they check before exercise. If it's too low, they take a unit of glucose, wait 15 minutes, and recheck. And you just keep repeating that pattern until blood glucose is normal. Typically, we should be checking during exercise as well, about halfway through if you're doing an hour session every 30 minutes, just to make sure blood glucose isn't dropping too much. Now, same is generally too for a type 2 diabetic. You want to check before and after as well. Now, there can be points where it's too high, right? Where your blood glucose is too high. And people say, well, wouldn't exercise just lower it? If your blood glucose is above 240, just have them run a couple blocks or something like that and get it down. Actually, again, depends on the person. If they chronically run into 200s, 240 isn't going to be super concerning, right? It is a little concerning that blood glucose is staying that high for so long. But generally, as someone's blood glucose is that high, again, like we talked about before, that signals, right, that there are not regulatory mechanisms to take in blood glucose. And when we first begin to exercise, we cleave glycogen, which will enter into the bloodstream. If we're already super high in terms of blood glucose, we have too much glucose in our blood, right? And we can't take it into our muscles to use it. If we start exercise, cleave glycogen, which goes into the blood, if that's the case, we're going to end up flooding an already flooded system. We actually may make their blood glucose worse. Again, these are just general recommendations. Always kind of base it off the patient's, what their typical levels are and monitor. But these are just some general recommendations to be safe. Now, exercise recommendations, very similar to the obese patients. We don't have a super detailed list here because quite often patients with type 2 diabetes are the patients that have obesity issues. But continuous aerobic exercise is going to be great for all those effects on the vasculature. Resistance exercise can be great for body composition. Generally the combination of aerobic training and resistance training, we think there's a combined effect there. It actually may be better, in terms of improving insulin sensitivity. We're talking about a type 2 diabetic, doing both or a combination aerobic resistance than doing either one by themselves. You kind of want to do a combination of both, especially for some of the functional gains you get with strength training that you don't get with aerobic training. Now, interval training is an emerging area for diabetics. One, again, patient enjoyment. People tend to like this mode a little bit more than continuous aerobic work. However, what we find even more interesting is that the high, blood flow velocity that occurs with high intensity, right? Because you do this peaks at like 80% of your max, that you don't really get to with moderate. Even though it's a brief period, that spike, we think that high velocity that's running through the blood and running through your circulatory system may better stimulate those endothelium, right, to produce nitric oxide, right? We think that may be one of the mechanisms for why we see actually insulin sensitivity and microvascular health get a little bit better in an interval-based program in diabetics. This is, again, an emerging area of research. Our lab actually in Chicago is looking at this to a degree, looking at microvasculature improvements in diabetics with exercise. So we think it may have to do with the high shear stress on the endothelium that you'll get with interval training that you don't necessarily get, but you get, but not at the same intensity with an interval approach. General rule of thumb, you want to make sure with interval training the patient's safe and stable. You don't want necessarily to start in an interval or at least a high intensity interval training approach with someone with poorly controlled diabetes and maybe has not done any exercise. So that's all I have. Sorry again about the little interruption there, and we'll get this added and we'll get this out to you guys. Thanks so much.